Good afternoon, everyone, and welcome to the fifth installment of the Beyond the Diagnosis webinar series. I hope you're all having a great lead up to the weekend, a happy Friday. Hosting today's session is Dr. Arjmand, can as you can see on the Zoom there. I'll let you introduce yourself to our audience, Dr. Arjmand. But before I do, I just want to remind everyone quickly: questions can be saved until the end of the presentation. If you'd like to pose a question, you can ask it either in the Q&A section of Zoom. You can type it in the chat, or you can raise your hand and I will allow you to unmute and you can ask your question directly through your phone, tablet, or computer. So Dr. Arjmand, if you'd like to take the wheel.
Absolutely. Thank you so much, Braden, and thanks to the Canadian Council of the Blind for having me this morning or this afternoon. It's a privilege and honor to be here. So we have an hour, as Braden mentioned, and I'll try to keep my presentation to about half an hour, 40 minutes, so we have plenty of time, hopefully, for some interaction and discussion if there's any questions from the audience. So for those of you who don't know me, I'm an ophthalmologist and a vitreoretinal surgeon or a retina specialist practicing in the Greater Toronto area. And I'm also affiliated with the University of Toronto. And I also work at the Baycrest Health Sciences Center, which is in Midtown Toronto. And so today I'll talk to you about 5 common retinal diagnoses that are relatively prevalent beyond a certain age group, especially in Canada and North America. And I'll provide you with some more guidance and help you hopefully kind of understand what questions to ask your retina specialist or your ophthalmologist or your primary eye care provider, whoever's following you for these diagnoses. All right, so these are my financial disclosures. I don't have any relevant disclosures to the talks today. And so today we're talking about this diagnosis because a retina diagnosis comes with a lot of lingo and unfamiliar jargon and treatment names, again, that can be very overwhelming, even if you're an academic or in healthcare. And often we get a lot of questions from patients that may not necessarily have been addressed at the time of the appointment, or sometimes these answers may be forgotten because of all the information that's thrown at you, for example, especially a first diagnosis. And so knowing what questions to ask and navigating your own diagnosis can definitely sort of set clear expectations for what happens at each appointment. And so, as I mentioned, we'll talk about 5 common retina conditions. And I will try to digress a little bit into plain language and give you a question list to navigate your own diagnosis if it is applicable to any members of our attendees today. And so in the next hour or in the next 45 minutes-ish, we'll try to cover the following topics. And so the number one is just what is the retina anatomy, and sort of some of the words that you may hear around the anatomy of the eye and the retina. And then we'll talk about age-related macular degeneration. Sometimes we just call it AMD, different forms of AMD. So that would be dry AMD, wet AMD. And then diabetic eye disease as well. This is a topic that's also very commonly, it's very prevalent in North America at all ages. And you might hear the word diabetic retinopathy or diabetic macular edema. So we'll talk about everything diabetes. And also the third most common diagnosis that we see in our medical retina practice would be retinal vein occlusion. Sometimes colloquially we call it a stroke in the eye, for example. And so we'll talk about that as well. And then we'll hopefully spend the majority of time at the end talking about any questions and having a discussion. All right, so before I start, there's a lot of confusion I find amongst my own patient base and a lot of even acquaintances and friends about the different eye care professionals. So there's a lot of different levels of eye care providers that you may encounter as you navigate your eye health. And this may be a bit confusing. So we call this the 3 O's of eye care. So number 1 would be your optician. Opticians go to a college for a college degree, and they're the professionals who cut your glasses and basically prepare your glasses. They do the ocular coating of the lenses that you get in your glasses. So they often work in an optometrist office. Optometrists are not medical doctors, but they're eye doctors, and their degree is an OD degree. They usually go to the University of Waterloo for their optometry school, or they train in the US and then they come to Canada. And they do 4 years of undergraduate education and 4 years of optometry school. And usually they see healthy, normal eyes, and they screen for any eye diseases, and they prescribe glasses. And then there are ophthalmologists. So ophthalmologists are medical doctors who go to medical school and then do a 5 year residency, and they're eye doctors and surgeons. And to see an ophthalmologist, just like any other specialist, you need a referral from your family doctor or your optometrist. So, what's a retina specialist? So, retina specialists are subspecialized, meaning they do 2 additional years of training after becoming an ophthalmologist to only care for the retina. So, I'm a retina specialist and a surgeon. For example, my path is 4 years of undergrad. I did 2 years of master's, 4 years of medical school, 5 years of residency, and 2 years of fellowship. So, on average, your retina specialist has around 15 to 17 years of training to care for your retina. And so, what's the anatomy of the retina? What is the retina anyway? The retina is a transparent layer in the back of the eye. And so, on the left, we have a picture of the eyeball, and the layer that's kind of, the orange colored layer, it's not actually orange in real life, but usually when you look at an anatomy of the eye, the retina is depicted as orange with lots of vessels. This whole layer is called a retina. It's sort of like the wallpaper of your eye, and that's where all your photoreceptors sit. And the very kind of a little bit off to the center, but essentially the center of the retina has an anatomical region called macula. So we all have the retina and macula in our eyes, and a healthy normal macula is what's responsible for your central, high contrast, 20/20 vision. So if you have excellent sight, that's probably because your macula is working perfectly. This is a color photograph. You might have had this done of your eye at your optometrist or your ophthalmologist office. We call this as an optos color photo, and it looks at a wide field, basically image of your retina. This is what a normal retina looks like. That center, this circle here is the optic nerve. So we all have a nerve, which is cranial nerve 2, or an optic nerve in our eye. And this circle here that's surrounded by these two big vessels, this is called the macula. So this area, this region is the macula, and the health of the macula determines the health of your central acuity. And the rest of your retina, where my mouse is now moving around, this is called the peripheral retina. So sometimes we look for diseases in the peripheral retina as well, and that affects your peripheral vision. This scan is a common scan that you probably have had numerous times if you've been to an ophthalmologist practice or even optometry. When you get this scan done by an MD, especially in Ontario, it is covered by OHIP because it's a mandatory part of your retinal exam. Patients sometimes refer to it as an X-ray or a CT scan. It's neither of those things. It's actually called an OCT, or an optical coherence tomography. There's no harm or radiation associated with this test because it uses light rays to take a picture of your cross-sectional scan of your macula. So this is called an OCT of the macula. And again, this is not an X-ray or a CT scan. It's just basically light technology cross-sectional scan of your macula. And a healthy normal macula should look like this. There's a straight line at the top, and it should dip down right in the center and then go back up normal. So this central area that kind of dips down, we call that the fovea. The fovea is the center of the macula, and the fovea is the most important part of your macula that has to be intact in order to be able to see very clearly. All right, so let's move on to some of the conditions that affect the macula. Today we'll be talking about those macular conditions as well as some retinal conditions that I mentioned. And so number one is age-related macular degeneration, or AMD. You may have AMD, you may have friends or neighbors or family members who have AMD. This is the most common condition in North America, including Canada, in patients over the age of 75. And so we'll talk about what that means. What is AMD? AMD has two forms, dry AMD and wet AMD. The most common form is the dry AMD. That's the earlier stage of the disease. And as the disease advances, it becomes wet AMD. So like I said, 90% of these AMD cases are dry. What does that mean anyways? What is this AMD diagnosis? Well, as we get a little bit older, there's a pump in our macula that every night pumps out the waste products in the back of your eye. It's sort of, you can think of it as a garbage truck in your eye that cleans up the garbage from throughout the day. But as we get older, this garbage truck or the pump stops working as effectively. And so the waste products that are normally supposed to be cleaned out from the macula start accumulating in the macula. And so that accumulation of those products are called drusen. You might hear the word drusen, that you have some drusen in the back of your eye. What does the drusen actually look like? It's these yellow deposits that you might see on the pictures. Your doctor might show it to you, or they might see it when they're examining you and mention to you that that's a sign of dry macular degeneration. I'll just call it AMD going forward. And sometimes AMD has no symptoms at all. In the majority of cases, patients don't even know they have AMD until it's too late, until it's too advanced, because it starts as early dry AMD and then progresses to intermediate dry AMD. So at the early and intermediate stages, often your vision is still perfect. But as it progresses to advanced dry AMD, you might get these areas of what's called GA or atrophy, geographic atrophy. You might have heard of the term, oh, you have some atrophy or shrinkage in the back of your eye. And unfortunately, that's an irreversible cause of vision loss. There is currently no treatment that's approved for GA in Canada. And that doesn't happen to everyone. Only a small percentage of patients progress from early dry AMD to advanced dry AMD. And we can't really predict effectively who's going to get GA and who's not, but we monitor patients for that. All right, so that's dry AMD. What's wet AMD? Wet AMD is when the dry AMD progresses to a point where the body produces abnormal new blood vessels in the macula, and these blood vessels, they can bleed, they can leak. So you might hear the word, you have some fluid or water in the back of your eye, you have some bleeding in the back of your eye. So fluid is plasma essentially, and blood is blood. You don't really want bleeding because bleeding is dangerous to the eye, but fluid is also bad. Most patients get fluid rather than bleeding. But when you do have that, that's an emergency. That's a conversion from dry AMD to wet AMD. And so when the disease progresses to wet AMD, you need to see an ophthalmologist, preferably a retina specialist, right away within 24 to 72 hours to get your treatment started. Because the sooner the treatment is done, the better the outcomes. We'll talk about that a little bit more as well, of course. But let's focus on the dry AMD diagnosis first. So, as I mentioned to you, it starts as early to intermediate and then progresses to advanced AMD. And it's the most common cause of central vision loss in patients over the age of 65 in North America, but rarely causes total blindness because patients are always worried, oh, I was told I have AMD, am I going to go blind? No, I think that chance is extremely, exceedingly low. Many patients have AMD in their eye for many years that does not affect their vision in any way, but you do need certain things, for monitoring and long-term prevention. So, first of all, let's talk about what causes AMD. What are the risk factors? Like why does your neighbor might have AMD but not you? So certain risk factors are age. That's the most common risk factor. Being over the age of 75 makes your risk of AMD at around 25%. And then family history, it's very strong genetic component. If your mom or your dad or your grandparents had AMD, there's a very high chance you may develop it as well. Smoking is a very strong risk factor. Even 5 or 10 years of smoking in the past can put you at risk. Secondhand smoke exposure is also a risk factor. Having blue eyes or generally a fair skin tone, so especially patients with red hair, blonde hair, and blue eyes are at high risk simply because of UV exposure and because UV can also damage the eye and cause AMD, as well as cardiovascular risk factors and blood pressure. So basically, any kind of heart disease or blood pressure issues can also put you at risk. Just because you have, for example, heart disease or blue eyes doesn't mean you're going to get AMD, but these are the risk factors. The main one I would worry about is mainly the genetic causes because you can have the healthiest lifestyle, but if you have a high genetic susceptibility to AMD, you should get screening as well from your primary eye doctor. So what are the early symptoms of dry AMD? It would be sometimes a gradual blurring of your vision in the distance or reading vision. You might notice that you need more light, more brighter environments to be able to see. Recovery from dark is a little bit slower when you develop dry AMD. That means when you're in low lit conditions, especially at night or in the evening, it might take you a little bit longer to get dark adjusted. So that's also a very early sign of dry AMD. So, when you get this diagnosis, your physician will give you a grid. We'll talk about that to test your own vision at home. And they also talk about eye vitamins that are very strongly evidence-based to slow down the progression of AMD. So these are some of the questions if you get a diagnosis of AMD to ask your physician at diagnosis. What stage is your dry AMD at? Is it early? Is it intermediate? Is it advanced? Because that will determine how frequently you need to be seen and what can be done potentially. Number two is, am I a candidate for these vitamins? The vitamins are called the AREDS 2 formula. AREDS stands for the Age-Related Eye Disease Study. It was a very large prospective clinical trial from the National Eye Institute in the US that showed that AREDS 2 formulation of the vitamins that includes vitamin C, vitamin E, zinc, copper, lutein, and zeaxanthin. This is a combination of 6 or 7 things in one pill, 2 tablets a day, really reduces the risk of progression of dry AMD. And so you should ask your physician if that's something you should be taking. And also, how often should I be monitored? Should I use a grid at home, which we will talk about? And also, what symptoms do you need to watch out for to call the office for? So, at what point do you need to be seen a little bit maybe sooner than your regular appointment? So, these are some questions that may be helpful to help you navigate that diagnosis. This is a grid you may be familiar with if you have a diagnosis of dry AMD. This is called an Amsler grid. We are supposed to use this grid by covering each of our eyes separately to check the function of the left eye and then the right eye, because a lot of times one eye compensates for the other, so you may not notice that you can't see until you cover one eye. And so it's very important to cover your eyes separately and look to make sure all the lines are straight. So normal on the left, but you might have a blind spot or a missing area that would look like this if you have disease in the eye, or lines may all be crooked or distorted as well. These are signs of some sort of macular pathology or macular disease that needs to be assessed. So whatever you see at baseline, if that changes, that prompts a visit to your eye care provider, that be it your optometrist, your ophthalmologist, whoever is your point of contact. So what's new in treatment? So let's talk about what's established. The established treatment is the vitamins, which produces basically it's an antioxidant treatment that lowers the rate of progression of dry AMD. As I mentioned before, it's over the counter. You can buy it at Costco or any other pharmacy. It's called the AREDS 2 formula. And then in the US, for patients who have advanced dry AMD, there is a treatment called complement inhibitor injections. These are injections in the eye for dry AMD. The drugs are a mouthful, pegcetacoplan and Izervay. Those are the two drugs that have been approved in the US. They did not get approval by Health Canada, so we don't have them in Canada, unfortunately, because they're not very effective. But we are looking at the pipeline in the next 5 years, hopefully, for some drug that might get approved that might slow down the progression of advanced AMD in the eye. And then there is another treatment called photobiomodulation, called PBM or photobiomodulation. It's basically light therapy that has been shown to help with patients with intermediate dry AMD. And it hasn't come officially to Canada yet, but it got Health Canada approval a while ago. And I think in the next month or two, the machine will be introduced to retina offices. And that's something that you can ask your physician about. It's called PBM, and it's also evidence-based. And then also, as I mentioned to you in the trials, there's many other drugs that we're looking at, but nothing else has been approved yet. So what's wet AMD? We talked about how dry AMD can progress to wet AMD, and that makes it an emergency where you need to be seen right away. That's when there's abnormal blood vessels that grow in the macula. They can bleed, they can leak, and cause vision loss. And so that's something I'd like to hear about. And I usually triage patients in my own clinic, for example, within 24 hours, because the sooner you get the treatment in, the better the final outcomes. So if you remember that OCT that I showed you, this is not normal. This is the OCT of a patient with wet AMD. You might see this kind of black area. This is fluid under the retina, or you might have what's called a PED. That stands for a pigment epithelial detachment, basically fluid accumulation at different levels under the retina. And that's a sign, it's a telltale sign of wet AMD. So when we treat the patient with this condition, these areas, these cavities should go away and the line should look a little bit more close to normal. So at the top, you have a patient who has dry AMD. You see these little bumps, but there's no fluid accumulation. At the bottom, that's when the dry AMD has progressed to wet AMD. So there's some subretinal fluid. There's fluid under the layer under the retina, as well as these little bumps. So when we treat the eye, this black area and this bump should go away. What are the symptoms? It's if straight lines suddenly on your grid become wavy, or even edge of the door, edge of a window, straight things are wavy or distorted. If you have a new black spot that doesn't move in the center of your eye, colors are less vivid. Basically, you can't read or see very well out of one or both eyes. And so that's something that you need to see your doctor right away. And you might hear about these needles or injections in the eye. So that's the mainstay of treatment for patients with wet AMD. That is the one and only treatment option available for wet AMD that works really, really well. This drug basically came into the market in 2004 and revolutionized the care of patients with wet AMD. In the past, if you had wet AMD, you would just go blind. But now you can have very good vision despite wet AMD for many more years, as long as the treatment is given. So this is not a cure. It's a therapy. Just like when you have blood pressure, you take blood pressure medications, or if you have diabetes, you take diabetic medication. When you have wet AMD, you get these injections in your eye on an ongoing basis. And so they're called intravitreal injections. The actual injection is an antibody that blocks a protein called VEGF. And so when you block VEGF, the fluid and the bleeding and the vessels regress in the eye so that macula can heal. There's lots of different drugs right now. In Ontario, at least, we're very privileged. We have coverage for Eylea HD, and Vabysmo for patients with wet AMD. Those are the top three common drugs used in retina. And Quebec and BC also have coverage. Basically, it's Canada-wide. If you have this diagnosis anywhere in Canada, you should have access to these drugs. And then there's other drugs as well. If you're younger than 65, or if you don't have ODB coverage, for example, your insurance may only approve the biosimilar drugs. You might be on Enzeevu, Yesafili, Aflivu. You can ask your doctor which drug you're getting. But the biosimilars is essentially similar to like generic version of the drugs. All the drugs work really well. There's not a substantial difference between these medications, but the newer generation of the medication, Eylea HD and Vabysmo, are a little bit more potent and longer acting than the first generation of the drugs. And so you're most likely probably have already been switched to Eylea HD or Vabysmo by your ophthalmologist if you're someone who gets injections in Ontario. So what do you expect? You're going to see your doctor for an injection. It's your first time or ongoing injections. What do you expect? I can't comment on how it's done everywhere, but the average, retina practice would be checking your vision, checking your eye pressure. A technician will be taking some pictures or scans, the OCT scans of your macula, and then you get prepped for your injection by your physician because these injections are an ongoing basis. So every time you see your physician, you will get an injection. But less and less frequently. So usually the first 3 times you get a loading dose once a month. And then after the third treatment, the treatment interval keeps getting extended to longer and longer, as long as the macula can tolerate the interval. And so you get these drops sometimes, or sometimes an anesthetic injection around the eye, depending on your preference and the physician preference. Then you wait a few minutes for the eye to be completely anesthetized, and then the physician will inject the medication through the white of the eye. And the whole experience should be completely painless. And I think these days we have very good, drugs and anesthetics to make sure at least patients are comfortable and have a painless experience as they go through this treatment, because this is an ongoing thing. And so, what do you ask when you get diagnosed with this? What are the questions that you should probably ask your physician for your own navigation of your condition? Which drug are you getting? You'd be surprised how many patients get injections in their eye, but they may not even know which drug they're getting. The importance of knowing what you're getting is because, if you read about something, you might see an ad, but it might help you navigate your own diagnosis and understand which drug is perhaps better for you, what worked for you in the past, or maybe another physician might offer you a drug. It just helps to know the name of your treatment plan. So ask them what anti-VEGF drug you're getting, or what are you getting started with anyways. And you may want to find out also why you're on particular medication. Maybe you had a poor response to another drug and then you were switched to a newer drug. So that kind of helps understand your diagnosis and management plan a little bit better. And a lot of these drug companies also have patient pamphlets, information handouts that your physician would be more than happy to give you when you go home, so that you and your family, for example, your daughter or your granddaughter, can help you also kind of go over the pamphlet and repeat some of the information if you forget it at the time of the appointment. So you can always ask for one of the pamphlets as well on the drug that you're getting. You can also find out what percentage of your vision loss is from wet macular degeneration as opposed to dry macular degeneration or cataracts or dry eye. And lastly, you could ask about what to expect in terms of how much vision you're going to get back, because patients sometimes wonder, okay, so is it going to continue to get better? Well, when you have wet AMD, you lose some vision potential. Some patients are lucky, they can have perfect vision, and others lose some vision potential despite getting the best injections. And so, the big good question to ask is to ask about your prognosis, how much vision gain to expect, and what's the treatment goal? Is it just to stabilize you, or is it to also improve the vision a little bit before stabilizing the treatment? So, these are some of the questions that might be helpful in terms of navigating the diagnosis. What's in the pipeline? So, I mentioned to you the newer drugs that we're very privileged to have free access to in Canada. These drugs are very expensive. They're $2,000 per injection, per appointment, per eye. But in Ontario and in BC and Quebec, I know for a fact they're all covered by our provincial health insurance, which is incredible. And these drugs are Eylea HD and Vabysmo are the two drugs that are currently the mainstay of the treatment for the newer generation drugs. There's also a port delivery system called Susvimo. It hasn't come to Canada yet, but that's something in the pipeline that your surgeon will put in the eye. So, for example, as a vitreoretinal surgeon, that's something I would do in the operating room. And then it's refillable. So you might come in every 3 to 6 months and just get that implant refill as opposed to getting an injection. It hasn't been approved in Canada yet, but that's currently in the pipeline. And also, the generic. So, the government has negotiated a contract with some of these companies that make the generic version of these drugs for cost cutting measures. And these drugs are supposed to be on par with the brand name medications. So, due to regulations in each province, your physician might have to offer you the biosimilar. So, you can find out if that's been done already and you can navigate again which drug you're on and the rationale for it. All right, so this is the end of the portion of the talk, which is the longest portion on macular degeneration. I will leave around 20 minutes at the end so that we can address any questions if there are any, because I do also hope to be able to get through these diagnoses before the end of our first 40 minutes of the talk. So I'll move on to the second diagnosis, which is diabetic eye disease. So in medical terms, we call diabetic eye disease, we call it diabetic retinopathy. So pathy means disease, retinopathy means disease of the retina, and diabetic retinopathy means disease of the retina secondary to diabetes. So if you have type 2 diabetes, especially, you need to have an eye exam right away with an optometrist at the time of your diagnosis, and then every year or sooner if you actually have eye pathology. You should know your hemoglobin A1C value, which is a marker of your diabetic control, through your family doctor. This is a number that your physician expects you to know every 3 months when the blood work is done with your family doctor, as well as your blood pressure and cholesterol targets. These values, if you forget them, it's helpful to have a journal or have these values tracked so that you take control of your own health. When diabetes affects the eye, so when you get diabetic retinopathy, it starts as non-proliferative diabetic retinopathy, which is not something that requires treatment, but it's a warning sign that things might get worse. So we grade NPDR, or non-proliferative diabetic retinopathy, as mild to moderate to severe. And then if a patient then progresses, if there's more bleeding and aneurysms and exudates, these findings that we see in the eye, if they progress to a point where there's bleeding in the actual vitreous cavity, or that presents as basically lots of black dots moving around because of the blood, that's called proliferative diabetic retinopathy. And then at that stage, you definitely need treatment in the form of laser or injections. And that's a pretty serious diagnosis. So we want to prevent that from happening by ensuring the patients get monitored regularly and that their sugar levels are well controlled through their family doctor. These are some of the findings that we see in patients who have diabetic retinopathy. So we see these yellow dots called exudates. We see hemorrhages within the retina. Hemorrhage means bleeding. We see cotton wool spots, which is a sign of a mini infarct in the retina. And we also see little aneurysms. We call them microaneurysms. An aneurysm is when your capillaries get dilated, and the dilatation of the wall of a capillary in the retina. And so this is, for example, a sample picture of a patient's left eye who has moderate diabetic retinopathy. And so if I see a patient like this, I would probably want to see them every 4 to 5 months to make sure if there's any concern for progression that I start treatment. This is a patient who has advanced diabetic retinopathy, so proliferative disease with lots of bleeding. These abnormal blood vessels are very dangerous and they need to be treated. Similarly, this is another patient who's previously had some treatment, but again, they've rebled despite the treatment. And so at this stage, basically, I would offer treatment to patients, and I'll talk to you about the treatment options that you may be familiar with if you already have diabetic disease. And your physician may also talk about your macular health if you have diabetes, because diabetes also affects the macula. which is the center of the retina. So you might get some fluid or swelling in the macula. So we call that edema or diabetic macular edema or DME. So on the left, you're looking at a normal scan of the OCT of the macula, whereas on the right, there's diabetic macular edema. And so, again, diabetic retinopathy that's advanced causes bleeding in the back of the eye, and diabetic macular edema causes swelling in the macula. And so, what's the treatment for these conditions? For the first one, if you have proliferative diabetic eye disease, your physician will probably offer you laser treatment. That's called PRP laser. It's a little bit painful. It's covered by OHIP if you're in Ontario. It's generally covered by your provincial healthcare plan. And it burns your peripheral retina so that there's less oxygen demand to the rest of the eye. And it's usually done in 3 or 4 sessions, so 3 or 4 appointments. And it's a permanent treatment. They might also supplement your treatment with the anti-VEGF injections. The injections that we talked about for AMD also are used for diabetic eye disease, and they work really wonderfully, but they're not a permanent therapy because the drug lasts for about a few months in the eye and then gets washed out. So the laser is necessary for the long-term management of eye disease. And then if you have only diabetic macular edema or swelling in the macula, then you definitely need injections. These injections may be forever or maybe just a few, depending on your disease stage. Your physician may also offer you a type of laser, rarely these days, but it's still done, called focal laser, if you have swelling in outside of the macula. And so, if you have diabetic retinopathy and you're seeing an ophthalmologist for it, the questions you should ask is, what stage of diabetic retinopathy do I have in each eye? And do I need treatment right now? Do you want to monitor me? How often am I coming back? And if you were to offer me treatment, what treatment would that be? Would that be laser? Would that be injections? These are questions that you could ask if you have diabetic retinopathy. And also, you could ask about how your A1C value is affecting your eye disease. Find out if you have diabetic macular edema. So as I mentioned to you, you can either have retinopathy or macular edema, or you can have both. And so it's important to know what type of diabetic eye disease is afflicting your eye. And also, as I mentioned, how often you need to be seen. Can your optometrist follow you, or do you need to see a retina specialist, and how often? So these are all questions that will help navigate this diagnosis on your own a little bit better. What are you looking forward to if you have diabetic retinopathy in the future? Well, the current established treatments are the PRP laser and the focal laser that I told you about diabetic retinopathy. Injections are super helpful. The anti-VEGF therapies make all the blood vessels go away, really make the eye look a lot better, but then they only last for a few months in the eye until you get another injection. So it's not a long-term cure, whereas the laser really helps. And also, as I mentioned, that long-term implant can also be used for this diagnosis, where we surgically put an implant in the eye and then we refill that implant every 2 to 4 months. Again, that's not approved yet in Canada, but it's in the pipeline. Steroids are another option for some diabetic eye disease. It's not used as often anymore, but your physician may offer you steroid injections in the eye if none of the other therapies work. So that's something that you can ask them about, or find out if you've ever had steroids treated in the eye for diabetic retinopathy or diabetic macular edema. So that's the end of the section on diabetic eye disease. And last but not least, we're going to move on to vein occlusions. This is a diagnosis that also affects patients who are over 70, 75 for the most part, but especially more commonly in the past, I would say 5, 10 years, we've had a lot of younger patients get diagnosed with RVO or retinal vein occlusion because of the prevalence of diabetes and hypertension and basically poor lifestyle choices that unfortunately some of our younger patients make that renders them at risk to an RVO. This is basically a blocked vein in the eye. It's not exactly a stroke because a stroke affects an artery. An artery provides oxygen to a tissue. So if an artery gets blocked, that's a stroke. You can get that in the eye as well. It's a lot more rare, but it's a lot more common to get the blockage of a vein. And if the vein gets blocked, there's a 30% chance that the vision will stay really good. There's a 30% chance that it might get worse, but then with treatment, it gets better. And then there's a 30% chance that it may be irrevocably gone. And that's for patients who have ischemia or lack of oxygenation to the retina when they get a blockage. It's not as common, but it really depends on what type of RVO an eye sustains. So there are generally two broad types of RVOs. There's a branch retinal vein occlusion, and then there's the central retinal vein occlusion. BRVO for branch, that means a branch of a retinal vein has been blocked. It's better to have a BRVO than to have a CRVO because a central retinal vein is the main vein that drains all the blood from the eye. And if that gets blocked, the prognosis is a little bit worse. And so sometimes you might have a BRVO, which shows up as a big area of bleeding in the eye that you may not even notice and only gets picked up on a routine eye exam. And that's why it's so important to have an annual eye exam with your optometrist, who will take photos and also look at the back of your eyes to make sure that none of these things are missed. And a BRVO would look like something like this. It's almost like someone took a paintbrush and painted red over the eye. And a CRVO would look like a blood and thunder appearance, where the entire eye is full of blood, the nerve is swollen, the vessels are squiggly. It looks, for the lack of a better word, kind of a scary fundus. It's because all the vessels are really congested. And so usually we call this the 3-month disease. When a patient gets a vein occlusion, 3 or 4 months later, their macula may swell up. So at the bottom, you're looking at an eye of a patient, an OCT of a macula. That's normal. And at the top, you're looking at the OCT of the macula of the patient's eye that's swollen from a vein occlusion. So all these cavitations, these cysts, and the fluid in the eye is as a result of vein occlusion, macular edema. And this is something that actually responds really, really well to intravitreal injections as well. So this is another indication for getting injections in the eye. And thankfully, this is a very good diagnosis to have compared to diabetic macular edema and macular degeneration. Vein occlusion, macular edema often responds a lot better to treatment, and vision is usually a lot better. So what's the risk factor? Who gets an RVO? Again, being older, so having age over 75. Elevated body mass index, essentially being overweight, is a risk factor. High blood pressure is the number one thing that we see in our practice. Poorly controlled hypertension, even 1 or 2 episodes of really high blood pressure can put you at risk for a vein occlusion. Glaucoma is also a risk factor. So if you have a diagnosis of glaucoma, it puts you at slightly higher risk for a vein occlusion, as well as a diagnosis of diabetes and high cholesterol, even if it's controlled by medication. So these are the primary top 5 or 6 risk factors for developing a vein occlusion. In younger patients, though, sometimes it's due to a clotting disorder like factor V Leiden, or if patients are really dehydrated, for example, or if they have a clotting abnormalities, that can also put you at risk for a vein blockage. So I think the main question to ask your physician would be, what type of retinal vein occlusion do I have? So is it a branch retinal vein occlusion or is it a central retinal vein occlusion? Because the prognosis varies. Do I need a medical workup for blood pressure, cholesterol, or clotting risk with my family doctor? And also, what treatment are you starting with? Do I need treatment? And if so, which injection, which drug am I getting? Some patients get injections, others don't need injections. And then some patients also need laser at some point when they have a vein occlusion. So these are all questions to navigate your diagnosis through your retinal physician. And the last thing I will go over, this is probably the second most common question I get from patients is, how many more injections do I need? So when are you going to stop treating me? It's unfortunately a little bit of a difficult answer to give to some patients. The short answer is, in the majority of cases, these injections are forever. For wet macular degeneration, we inject the eye forever. At least in 2026, there is no treatment that cures AMD. Unless if gene therapy comes to the market, we currently have to keep going with the injections, ideally every 3 to 4 months. If we're lucky that we can extend the treatment up to like 16, 18, even 20 weeks, but we're not going to stop. Then the situation when I do stop treatment is when the vision is so profoundly gone and there's so much vision loss that there's no benefit to doing injections. That's when I stop and then focus on the good eye. Or if in a minority of percentage of patients, maybe 10% of patients only need a few injections and then they don't need injections again, but we can't predict who can stop treatment. So we don't stop treatment unless, let's say, someone gets sick, they get into the hospital, they forget to come back for a whole year and they miss their injections for a whole year. When I see them again, the macula is still fine. That's the kind of patient that I might say, fine, you know what, let's not treat you and let's just observe you to see if the disease is going to come back. But for the vast majority of patients, the injections are continuous, just less and less frequent. So that's what AMD. With DME, you can stop the treatment if The diabetes is extremely well controlled, and the macular edema doesn't recur. But I would say 80% of patients need injections for life. And for vein occlusion patients, 50% of patients only need 8 injections and then you can stop, whereas the other half probably also need injections forever. So it really depends on your diagnosis and the anatomy and the health of your eye, as well as your systemic health. So these are, again, also questions to ask your doctor in terms of whether your injections are forever or if at any point your physician may try to stop the therapy. So this is the summary of everything we talked about. I'm more than happy to share my slides with you guys through the Canadian Council of the Blind to share with the audience if you wanted to take notes or go back to these slides. And I now like to just take up some questions. Again, my name is Arjmand. I'm a vitreoretinal surgeon and retina specialist. I practice in Mississauga at the Mississauga Retina Institute. I do surgery in Burlington and also see patients in Toronto 1 day a month. And many of my retina colleagues are available across the country, and we get referrals from optometrists and family doctors. And generally, either in small towns, it's ophthalmologists who take care of patients with retinal diagnosis, but in big cities like Toronto, Ottawa, Montreal, retina specialists often take care of patients who have retinal diagnoses. And that's my contact information through my office. My personal contact information as well. I'm happy to share if you reach out to Braden. So I see that we have 18 attendees, and I'm happy to take up any questions that any might have come up throughout the talk.
We do have, well, first I'd just like to say thank you, Dr. Arjmand. That was incredible and very informative. I know I learned a lot, and I'm sure others did as well. We do have a question from Hilton. I will allow them to unmute. Hilton, you should be able to ask a question now. You just have to unmute.
Hello, can you hear me?
Yes, we
Yep.
can hear you.
Thank you, Doctor. It was very, very informative. My question is more from the behavioral side than the technical side, which you handled very well. And I'll ask you to pull back the curtain a little bit as much as you can. So I'm going to just draw a narrative that this doesn't apply to me, but I'm just trying to, get the story going, is that I have dry AMD. I feel some change in vision. I go see my optometrist. Says, "Oh my God, you've just transitioned to wet AMD. You've got to see a retinal surgeon right away." It's July the 5th. The place where I live has 5 of those. 3 of them are on vacation, including mine. And I start calling around to see who's going to treat this quickly. So I have 2 questions around that narrative. The first is, what should be my strategy to find somebody to give me this urgent surgery or any urgent surgery? I just chose as an example. In a worst case situation, middle of July, everybody's on vacation. And my second question is, from your side of the curtain, as much as you could reveal, you're one of those 2 out of 5 retinal surgeons that's not on vacation, and you start getting a lot of calls and you start working 18-hour days, and all of a sudden you get a call from me. It's 11 o'clock at night. You've already done 3 operations, and if you don't see me, I'm going to lose my vision. How do you handle that?
Okay, thanks, Mr. Hilton, for your question. So number one, let me just clarify. If you have a wet AMD, you actually don't need surgery. You just need an injection in your eye in the clinic. And the whole thing takes about 5 to 10 minutes. So thankfully, it's not as big of a process as you may imagine. But we do also see patients for emergency surgery, of course. That's usually for patients with like retinal detachments and so on. But let's say you have a diagnosis of wet AMD and your optometrist is worried. So it depends on where you are. It depends on kind of what relationships your optometrist has with the local retina specialists. For example, in Mississauga, if I get a referral for a wet AMD patient, I triage it within 1 to 2 days by myself or one of my 4 colleagues. So there's 4 of us in my practice, and one of us will see you within 1 to 2 days. All right. And then we'll take care of you in the clinic. And the whole thing, as I mentioned to you, it's a relatively quick and straightforward procedure. But if you are in a smaller city where you only have 3 or 4 people available, the worst case scenario is okay, so if no one can see you within 1 to 2 days, you go through the emergency department at a hospital that's affiliated with an ophthalmology department. So they have an ophthalmology department in Ottawa, in Montreal, and London, Ontario, Kingston. Basically, every city or town in Ontario should have a hospital with ophthalmology service. And you don't necessarily need a retina specialist in a smaller town. Ophthalmologists also do injections. And so your, worst case scenario is you go through the emerge, and after a few hours, you get seen by ophthalmologist either same day or the next day for your injection. And then, so yeah, for emergency surgeries, that's a different story. So when we're on call, usually we see even up to 13 patients who need surgery, and we just operate either that day or the next day. Usually everything can wait within 24 hours for surgery. And so it's not as difficult as you may imagine. Thankfully, we're lucky we have resources, a great nursing team, and they're able to accommodate emergencies. So hopefully that answers your question.
Yes, thank you very much.
You're very welcome. I see here a question in the chat from the GTT program. Seems to be slowing down. So
Yeah.
someone said, thank you. You're very welcome. Thanks for joining the talk. Says my mom is receiving Vabysmo and it seems to be slowing down the progression of macular degeneration. Your presentation provided a lot of information as to what steps and lifestyle changes we can make. As someone, oh, okay, I thought that was a question, but yeah, you're very welcome. I'm glad that that was helpful. Your mom, you spelled the drug correctly, and that's one of the latest drugs in the pipeline. So Vabysmo and HD are the two drugs that are at the forefront of the treatment for what your mother is getting. Are there any other questions from the participants about anything that may have come up or in terms of navigating the healthcare system?
Yeah, so in the Q&A, it comes up as anonymous, but someone asked, what is something you wish all patients knew when they get diagnosed with retinal disease such as AMD?
Very good question. Many things, but I think the number one thing is I want patients to know if you have wet AMD, please don't miss your appointments. Sometimes you get, God forbid, you get sick, or you might end up in the hospital because you're having a fracture or any type of surgery. You may forget that you had an injection appointment or you had some sort of follow-up appointment, and you may miss that. And then 6 months goes by, and then you will lose your vision, and that's too late. We really don't want that. So one thing I want for everyone to know is if you have a diagnosis that requires you to see a retina specialist, especially if you're getting injections, if you miss an appointment, please make sure you rebook that appointment. Make sure your follow-ups are scheduled. Let's say you don't like a doctor, find another doctor. Make sure someone is seeing you regularly for your injections because if you don't get your injection, you can go blind overnight. And we don't want that for anyone. We don't want to see you when it's too late. I hope that answers the question. I also do want patients to know that, as I mentioned to you in my talk, sometimes patients are like, okay, well, I've had like 31 injections. How many more do I need? Again, if you have wet AMD, unfortunately or fortunately, the treatment's ongoing. So as long as there's vision potential in the eye and your physician thinks that the injection is stabilizing your sight, they will continuously treat you because if they don't treat you after a few months, the disease will come back and then you might get a bleed or lose vision overnight. So again, the injection is an ongoing commitment. An ongoing treatment. So it's kind of like if you have diabetes, you have to take your pills forever, right? It's the same thing. You have to get these injections essentially for life.
There's a question from Amanda, a personal question. What made you choose ophthalmology?
Okay. Well, I was fortunate in that my father was an ophthalmologist. I grew up in Iran before my family immigrated to Canada when I was a kid. And my dad was the ophthalmologist for the small town where we lived. And so I saw firsthand the impact he made on a lot of families. He used to see children as well as part of his practice. So a lot of my classmates had eye problems that my dad fixed for them. And so I felt like that was a really great thing to do, as a career. And I personally have always had to wear really thick glasses. And so I've had to see a lot of eye care providers growing up. And so I feel that I really felt that eye care was meaningful and changed people's lives. So when I went to medical school, I wanted to be a surgeon and I explored all different surgical specialties and really, really enjoyed how rewarding ophthalmology was because our patients are really happy. We can make a big difference either with surgery or with clinical care, with medical therapies as well in their life. And so there's a lot of happy patients. So it's very gratifying. That's why I chose ophthalmology.
Are there any other questions? Amanda says amazing.
Thank you. I'm curious where all the participants are from. I mean, obviously, due to confidentiality, we won't ask for anyone's full name, but most of the participants, are you mostly from Ontario or is it all from all over Canada?
Sharon's from BC. Just looking at some of the names in the chat.
Oh, wow.
Um, I would think a lot of people. I I know we have at least one person from Atlantic Canada.
Wow, very cool. So
Oh, yeah, there's Louise,
when
Nova Scotia.
one thing our audience might find interesting is that retina in Canada, wow, Alberta, okay. So retina in Canada is a very small community. There's not that many of us. There's probably around 150 retina specialists combined, medical and surgical across the country. Probably even less, maybe 100, 120. And so we all know each other for the most part. And we go to meetings where we all see each other every several months. And so if you're moving provinces or if you're on vacation, the chances are that your retina specialist from home has a whole bunch of friends in the city where you are. And, if you need to transfer care or get emergency care if you're traveling, it's not as hard as you think because, again, there's a network of retina specialists. We're all colleagues, we all know each other, and care can definitely be arranged even across the country. Comox. All right. I think I know the ophthalmologists in Comox. Very cool. Um, Braden, is there any other topic, I guess, if there's no other questions from the audience that you'd like me to go over?
No, I think this has been great. I don't think there's any other questions. I'll just check if there's none in the Q&A comes up in a separate section here, but nope, nothing there. Oh, Bev says thank you. This has been amazing, and I can't agree more.
Very kind. Thank you so much. I really appreciate that you dedicated your lunch hour or perhaps out west, out east at different times to join this talk. It's such a privilege to care for patients and especially to have this opportunity through the CCOB to be able to provide further information outside of the clinic because I do find all my patients always have so many more questions that they would like answered. And so I hope this was helpful. If anything comes up, you're welcome to contact me or get my contacts from Braden. And I'll let you guys go and enjoy the rest of the weekend.
Thanks so much, Dr. Arjmand. This has been excellent. And just a reminder to everyone that our final session for the Beyond the Diagnosis will take place next week on Tuesday. And it's being hosted by the Get Together with Technology team. It starts at 11:30 on Tuesday. And yeah, I'll send out a recording of this session on, well, next week. I don't think I'll have a chance to edit it today, but thank you very much, Dr. Arjmand, for your time and your expertise. And I look forward to seeing everyone next week.
Thank you for having me. Bye.
Bye.